Great. What's our number at? 21. That's certainly going to be a quorum, I would imagine. So why don't we go ahead and get started? We'll call the meeting to order. And can we please call the roll?
I will. Dr. Rick Hildebrand.
Here.
Rob Chapanelli.
Here.
Dr. David Coderre. David Coderre. He was just in licensing, but we'll see him in a minute. Dr. Evan Eiler. Gail Falk.
Present.
Dr. Rachel Gatiss. Dr. Matthew Greenberg.
Present.
Dr. Peter Ireland.
Here.
Dr. Patricia King.
Present.
Stephanie Lawrence. Dr. Ian Udeji.
Present.
Don Philibert.
I'm here, present.
Judy Scott.
I'm here.
Dr. Margaret Tando. Dr. Robert Tortolani.
Here.
Scott Tucker.
Here.
Megan Campbell.
Here.
Kurt Keel.
Present.
Bill Reynolds.
Here.
Justin Schenk.
Here.
Scott Frenier.
I'm here.
Tracy Hayes.
Here.
And Paula Nenninger.
Here.
Okay, we
Great.
have a quorum.
Excuse me, David.
Yes.
We also have Kelly Lawler on the call.
Okay, thank you. Thanks, Kelly.
Okay. And I see,
And David Coderre just joined.
and it looks like Margaret Tanner was coming in
Margaret.
too. And we have Jessa from the Medical Society as a guest. Is there any other guests that are present? No? Any public comment? Hearing none, we'll move on to the approval of the minutes from the July 3rd board meeting. And if you've had a chance to review those, I'll entertain a motion to approve the minutes from July 3rd.
So moved. Scott.
Great. Can I get a second?
Second, Philibert.
Excellent. Any discussion? All those in
There's, I
yep.
just have one point, Rick, on the return to open session and where we vote on matters discussed in executive session. It lists me as asking to close for North Committee, and I think it should be Don Philibert.
I believe you're right.
Thanks for picking that up, Pat.
Yep.
Great. Any other discussion on the minutes? If not, all those in favor, please say aye.
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 Any opposed? Abstentions or recusals? Great. In terms of board issues, the only board issue, which isn't an issue, is that we have our newest member here today, Dr. Peter Ireland, joining us for their first full board session. If you wouldn't mind just introducing yourself and maybe telling us a little bit about your practice and what drew you to the board, we'd love to hear it.
Well, great. Yeah, I'm Peter Ireland. I'm a full-time primary care physician out of Waterbury, Vermont. I've been here for about 4 years, did my training out in Missouri where I met my wife, and just had a new baby, 7 weeks old at home now. I came here and I took over for a retiring physician, Bill Cove, and since then I've picked up a number of panels of people who have also had to leave practice. So I have a complicated, high-risk, high-prescribing panel, a lot of chronic pain. I do a lot of work with opioid addiction, Wednesday mornings, I have my buprenorphine clinic. And we see cradle to grave, newborns to, I think I recently had a 109-year-old. Let's see, outside of that, I'm a dual Vermont and Florida licensed physician. About 10 to 15% of my panel are snowbirds. So I do a little bit of telemedicine like that as well. Living down in Waitsfield, love it here. I heard about the open seat when my colleague Chris Payne moved to Maine and had to step down from the board. I've always liked helping out with committees and administrative matters, but didn't really find a taste on the corporate end. And the board matters seemed like they had some real world impact and were substantive, and I'm happy to be helping out.
Great. Well, welcome. It's always wonderful to have an experienced primary care physician, especially one that has your patient population and some of the addiction challenges that sometimes come to the board. So really appreciate your presence and perspective, and welcome.
Welcome.
Thank you.
Rick, I'm sorry, I have to interrupt because Dr. Ireland left out the most important thing about him. He is a new father. Just
He said 7-month-old,
weeks-
yeah.
Weeks in the game.
Oh, weeks.
it-
Weeks.
yeah.
Oh, weeks.
Oh,
Ah,
geez.
getting any sleep?
We're starting to. As of last night, we started to realize that nighttime is for sleeping. But she is doing well. If I could burden the open
Oh.
Oh,
baby Robin, 7 weeks old.
Adorable.
So,
That's great.
what's her name?
Robin, like the bird.
Nice.
Nice.
Lovely. And how old is she?
7 weeks old, about to turn
7
8 weeks.
weeks, a tiny one.
Oh yeah. Well, she's 12 pounds. She's healthy.
Okay.
Nice. Congratulations.
Thank you.
Congratulations.
All right. I don't have any other board issues, and we can move on to an administrative update by David. Take it away.
Sure, just a few items. We sent out a mass email to all licensees last week. I hope all of the licensees received it and saw it. It was one of the shorter ones we sent out, just 3 items. We had the joint statement on IV therapy clinics and new guidance on death determinations and a renewal reminder. We've already started getting in inquiries and responses regarding the joint statement on IVs, as you might have expected, not too surprising. Next item, we have finally hired a new employee for the additional position that we were able to get approval for. And she is going to start next week. Her name is Marcy Quinlan, and we're really looking forward to having that extra help for Tracy and Kelly. Next item, the office is closed next Friday, August 16th, is every state employee's favorite holiday, Bennington Battle Day. And we will be celebrating it by not going to work. So Central Committee is pushed this month to the following week, August 23rd. Central will be meeting. And last item to note is that the North Committee meeting is going to be in person this month, the same location as last time at the lab building in Colchester. And if anybody has not gotten their menu request to Kelly, please make sure you do that.
And I will not be there, David. I'll be away. And Pat King will be running the meeting. And Pat, I will send you some notes about my cases.
Thank you.
Thank you for doing that.
Okay, and that's it for the administrative update. Well, actually, one last item I'll just mention because it's such a big part of what we're doing now, and it's administrative. The IT project is really a dominant force and at least in my work week, spending 25% of the hours probably in meetings and a lot more time outside of the meetings preparing. And it's also taking time from Kelly and Tracy, especially Tracy. So, and Ron as well. And Ron is out this week. I should mention that. He'll be back next week. He had a pre-planned vacation. So that really now is the end of my admin update.
Okay. Any questions for David on any of those items? No? All right, we'll move on to other business. I think there's just one item of other, well, other than the hearing, but and that's the draft revisions to the Board of Medical Practice rules. I believe you all received a longer document that was detailing this, and there's a blurb in the agenda. David, do you want to describe this in more detail?
Sure. So again, this is we just finalized our last update to the rules, became effective on July 1st, and so it was time to get this one in the works. I didn't want to try and have two going at once, and that the health department has a significant role in herding these through the process, and so we did wait until the other ones were finalized before bringing these to you, and there I hope everybody didn't try and read through the entire 80 pages. I did provide a document that has a summary of all the draft changes, and I don't know if everybody wants to listen to me go through those one by one. Almost all the changes are the result of the license process review that we conducted last fall, and the board was required to do that by statute, and we had certain things that we were required to look at, but we looked at everything, and the board made a number of decisions about some fairly significant changes to our process, and several of those needed to be in order to be effective. Several of them needed to be put into rules revisions. And so that's the major impetus for this. There also was a vote by the board to increase the penalty for failure to update contact information. And there was especially for the newcomers, there was significant discussion about that. It had been a set in rules as is required by the law creating the non-disciplinary financial penalties. It must be stated in the rules, and it was set at $25. We continue to have just a really shocking number of licensees not keep their contact information up to date, and it's really I think as we started processing these and members saw how many we have and what an impact it has on our ability to do our job, members thought that it should be increased significantly, and the direction that we were given, staff was given via a motion passed last fall, was to raise the range to be from $100 to $250, which is the maximum penalty, and that the range, the penalty within that range would be dependent on the how significant the impact had been on the board, and that I mean, we can talk about that more if anybody is interested in why we went to that level, but there's just an incredible number of the renewals that we send out that get returned to the board as bad addresses. You know, this is within days or at the most weeks of when the individual does their renewal. So it really, and that takes time, staff time to you know, process the mail coming back and to then try and track down where the person actually is so that we can reconnect them with their license, to print another copy of the license. And it's just really been disruptive. It's also disruptive in the investigation process. Very often we have delays in the investigation process because we can't track people down without a lot of effort. And so that's been increased. So anyway, Rick or everybody, I don't know if people have read over the summary of the changes, or Rick, do you want me to go through the summary document that I provided with the agenda?
Well, Pat has her hand raised. Let's go to her.
Yeah, I can wait until David's gone through the summary. I have a couple of questions because I read through the big document and just a couple of things, so I can hold on.
Sure. Yeah, be much appreciated. So the last thing I should say is just about the process. The actual issuing authority, it's the Department of Health as part of the Agency of Human Services is the issuing authority. And they're the board rules, but they're issued by the agency itself as on behalf of the board. And so this today, your approval is just your approval to me as the staff employee who is preparing these with the Department of Health, and your input and direction will help me get the final version that is presented to the department in order. And then there is a process of editing and review by BDH staff, and then we will go into a prescribed pathway of review by an interagency committee. And then once that comes back, we will be taking public input at a public meeting that needs to be warned in advance. And we also will reach out to a number of stakeholders, including BMS and the PA Academy, other interested parties, VAS, the Association of Hospitals and Healthcare Systems. And so once that entire process is all done and we get to a final draft, that will then go before a committee of the legislature, and then they will give us their approval, hopefully. It takes, because of the requirements for all these steps and notice periods, it does take several months. So it'll be a little while before this is all put into play. All right, so going over the changes one by one, the first one on page 2 of the draft document that has the underline and strike through of the changes is to add a definition for FCVS, the Federal Credential Verification Service, on page 2. The second change is revisions in 9.22 on the process for reinstatement of a license or certification. And in that, it's the first point in the rules where we see the board's direction reflected to make the use of FCBS a requirement for MDs and PAs. And the FCBS is, again, the Federation Credential Verification Service. It's a certified repository of many pieces of documentation that in the past had been collected by the board. And many of our licensees now use FCBS in the application process. And it really works quite smoothly now. And it was recommended by licensing staff that we opt into having FCBS a requirement. It had been accepted for many years. We hadn't made it a requirement. New Hampshire and a number of other states had made it a requirement. I think when we presented this initially, and the board passed a motion to call for it. I think we were at 17 or 18 states where it's a requirement, and there is a cost to the applicants who are required to use it. But again, we are finding that a large number of our licensees already use it, and it seems that most residency programs now have their participants enroll in FCBS while they're in residency, and start using it then. So it's only going to grow, and this is really going to there's going to be a cost to the applicants, but there's going to be a benefit. Our process should become faster and less burdensome for them. And some part of the cost involved with using FCBS will be offset by savings in the future as they apply for different licenses and for credentialing with different employers or different insurance companies. They will be able to get all their documents they need for those processes without the additional cost that it typically costs money to have obtained verifications every time. So that's FCBS, and again, it's only available to MDs and PAs. So and well, DOs as well, but that's a point with us. So our other professions are not included in that requirement. Number 3 is revisions to section 15.2, which is the MD licensure process. And the board, the first and one of the most significant changes is the board will no longer require all applicants to have references complete the form and send it to the board. Instead, we're going to be collecting the name of references and contact information for them, and they will only be contacted in the event the licensing committee determines that additional information about the applicant should be obtained. And the changes here in the rule also relax the requirements for who may be listed as a reference. In practice, we had been allowing MDs to use DOs, and it was made clear in the rules now with these changes that a DO may be used as a reference. And also, in appropriate circumstances, a DPM may be a reference for an MD. We've seen instances where physicians practice doing, say, an orthopedist who specializes in lower extremities. We've had applicants who the people who are in the best position to give them a well-founded reference were DOs who they practiced with. So the board determined that that should be an option for, and those changes are reflected in the rules that are before you, the draft rules, I should say. This change, I know the board has already decided, passed a motion calling for this, but for in case you don't recall, or with our new members, I'll just share that the reasons behind this is that really a large percentage of all these references that we spend so much time collecting and requiring applicants to obtain, and requiring physicians out there who we hear so much about physicians being overburdened by administrative matters, and that contributing to physician burnout. And in the end, most of these references were never seen by any board member. Only the applications that went to the licensing committee were they being seen. And many of those reviews, there wasn't really a reliance on the references, the specific issues that gave rise to the need for the review by licensing. Didn't necessarily they weren't important for resolving the issue, and so we reached out to other boards and found that a number of other boards were going in this direction, and finding that it worked well, and this should significantly reduce the amount of time it takes for an applicant to get their application complete, because typically references were among the last items that came in, and were very often the only thing holding up the application from being approved. So this should improve the service that we provide our applicants, and make life better for the hospitals and other employers who are trying to get new physicians and other licensees to work. The fourth change, I already spoke about this the first time it came up in the context of the reinstatement applications, but in 15.3 is where we lay out the requirement for FCBS in our initial physician application. And in the rule, we go through and list all the different pieces that are to be provided in the FCBS packet. And that just was being cautious to make sure. Sometimes as much as FCBS does a really good job, and they're very accurate and have been improving over time. We just wanted to make sure that it was clear we needed to have all these pieces of information. So if something was missing from the FCBS packet, that we would have it in the rule that we still needed to have these pieces of information. Next change, number 5 on the summary document. And this is another pretty big change, I think, that is going to please applicants. At 15.3.1, we're deleting the existing requirement for submission of a birth certificate or a naturalization certificate as the required document for identification. And we are going to go to the process that most states now have gone to, which is using the FCBS certification of identification form, or their own version of that form, which is basically the form with their name on it. And that's what we plan to do. It allows the applicant to have a notary public examine specified forms of identification that are acceptable and certify the applicant's identity based on that. And the board had considered this several years ago and decline to move away from the birth certificate or naturalization certificate. Those are some of the most reliable sources of identification because there are legal limitations on the issuers of those for who they can be provided to. And it's reliable, and you don't need to rely on the integrity and accuracy of the notary public who will now be a part of the process. But there, the reality is that now information is so much more available. I think that there's such a web of information out there, and I don't mean just the web as we talk about the internet, but there's so many different sources of information. I think that we're a little bit more comfortable with accepting this, and again, this will simplify the process. We especially with some applicants who are born overseas or applicants who are from jurisdictions where there's a cumbersome process for obtaining a certified birth certificate. That was an inconvenience and a delay factor, and so this should reduce the admin burden and speed up the process of getting licensed. So and again, I should say, if anybody sees problems in the wording, you can speak up now. You can email me comments. The first concern here is the substance, and are you okay with what we're doing here? But also I appreciate all your editing help. I got some from Gail Falk, sent me some helpful editing comments, and you're all welcome to do that.
David, I'm sorry. I have a question. At the bottom, it's not a footnote, it's whatever that's called. On the bottom, it says final adopted rule effective 4/1/24, and that's redlined, and then 4/1/24 is written in. I'm wondering, why is it
that's just, I started with another document that was the basis for this last update to have the latest version, and that's you can ignore that. I'm sorry.
Okay. All right. Thanks.
Okay. So back to the summary document number 6. The requirement for documentation of completion of high school and 2 years of college has been deleted. The reality is that we don't document that now formally in the process. It is effectively documented because of what medical schools require. It's also with regard to our international graduates. Sometimes they have a different system. Their first 2 years of medical school are effectively the same as 2 years of college would be in our system, and so it really has not been something we've done for a long time, and it's not part of the FCBS process, so that's been taken out of the rule. At number 7, at 15.3.6, the wording is changed to delete the requirement for medical licensing exam results to be sent directly to the board. And again, that reflects the decision that we would accept FCBS as a certified repository of this kind of documentation to reduce the administrative burdens associated with the licensing process. Number 8, at 15.2.9, the reference requirements are deleted. The references are not part of the FCBS process, and the reference requirements were moved up to 15.2 at page 11 of the document, where the requirements for what must be provided directly to the board are listed. And so that's why structurally we changed the position, and you're going to see that later on with other professions. Number 9, beginning at section 15.4, there's a list of 3 items that are apart from the FCBS packet that have to be submitted to the board. They're not new requirements, but the few pieces of documentation that are not taken care of by the FCBS packet. So those are, they're things that we collect now, that we require now, and they're just set off and in a slightly different structure and the way the rule is laid out, because they are they're not in the same category as those things that are coming in the FCBS packet. Number 10, section 16.0 is all about an abbreviated process that allows some physicians licensed in other jurisdictions to rely on their good standing in another state in lieu of providing certain documents. This is something that we were required several years ago. I think it was in 2016, 2017. We were forced to put this in our statute to be consistent with all professions in Vermont. And users of that process will not be required to use FCBS, so that section is largely unchanged. But we did make changes in this section as well to the new reference process to get just names instead of reference documents that have been filled out. Was those changes were also put into section 16.0. And just one footnote on that, I don't think we let people know about this. It's on our website. It's an option for people to do. It's in the rules. We've yet to have somebody apply using that process. And I think it's just the lack of familiarity with it. And rather than trying to figure out this different thing, they just have been using what's familiar to them. Number 11, section 27.0, we're changing gears and going over to the PA section. So a lot of the same things we've talked about, but just as applies to PA process. And the licensing process for each of our professions is listed separately because they all have their own little quirks and talk about different licensing exams and different sources of information that are required. So the changes to reference procedures are seen in 27.1.2. The wording is not quite identical to the MD section because PA requirements are a little bit different, but the idea remains the same. We're going to name and contact information and doing away with the forms. And again, that if the licensing committee decides that they have concerns about that they want to hear from somebody about the competence or moral readiness to practice medicine of the applicant, we can ask for a form to be filled out or to get a written reference, but they are not going to need to submit their written references. Number 12, as with the MDs, PAs are required to use FCBS. And again, the information that we collect about PAs is a little bit different. And so we list out what's required and will need to be in the FCBS packet. And that's all in 27.1.3. Number 13, same idea with podiatry. Again, podiatry, podiatrists cannot use FCBS at this time. I think I may have heard that they're working on trying to I want to say there is a separate federation of podiatric medical boards, but I think they may be discussing the idea of trying to get into FCBS. But at any rate, they aren't now. So we aren't going to require that of podiatrists. This begins at section 34.4. And so we have similar changes about the references in there. And we also provided some clarification about who may provide references for podiatry applicants. And we also moved the where the reference provisions fall in the rule, just to be more consistent with the MD and PA sections. Section 34.5 reflects the changes to the identification process. Now here, because we are not relying on the FCBS identification, we are going to be using our own form for all the podiatry applicants. It's going to look a lot like the FCBS form, but it's going to be our form. And but it's the same idea. They're going to be able to go to a notary public with their passport or other specified pieces of reliable identification and get the identity form filled out. Number 15 covers section 36.2, which is the same as with the MDs, the process that's available to licensed podiatrists who are in good standing in another state. They have the option of a shortened list of requirements for the application process, and that their current licensure and good standing takes away the requirement for certain pieces of information. We've never seen a podiatrist apply using that process, but it's there and it's going to stay there. We're required to by law. In 36.2.9, there's also a correction of a typo and a minor non-substantive rewording, just to make the sentence flow a little bit better. Number 16, we're getting close. There's only a total of 19. Section 49 covers the certification requirements for anesthesiologist assistants. And again, with the AAs and the RAs, they don't get a license, they get a certification. And so the 49.1 is revised to change the reference requirement again to only name and contact information. And new language about the identification process, similar to the changes made in the podiatry section. Because AAs aren't able to use FCBS either, is added in 49.1.3. Number 17, section 50.0 is deleted. That section allowed for issuance of a certification to certain applicants who had not passed the national certification exam. Tracy and I don't really know where this came from. There's a provision that allows the board to do this in the law. And so I think just to make it available, because the law made it available, it was added to the rules. Tracy reports that we've never had anybody ask about getting one of these, and we've certainly never had an application for one of these temporary certificates of somebody who's not passed a licensing exam. Tracy and I talked about it. I think that everybody kind of believes that none of our facilities who use AAs or RAs would hire somebody who hadn't gotten a passing score on the national certification exam, they probably wouldn't be able to bill for their services, or might not be allowed to let them work because of liability insurance concerns. Whatever the case, we propose taking it out because it's just taking up space in our rules, and there's no reason for it. We've never had anybody even ask about using this.
David, can I interrupt?
Sure.
Peter Ireland. When I was coming to Vermont, spring of 2020, it was a fun time to try and be getting a license. And during that time, licensing exams were shut down because
Yes.
Prometric just wasn't allowing people to come in due to the pandemic.
Yes.
At the time, it was a real question if, I was even going to be able to get in to do the required testing that, I passed fine and easy. But that would be like an edge case scenario if for some reason testing was disrupted by something like that again.
Yeah.
Very edge case. I hope it doesn't happen again. But just one thought of where something like that might come in.
Well, I think that we would be able to we could address that if it came up. We could address it with an emergency rule. If we saw that as a problem, and we actually did that during COVID with the we made changes to the time limitation for passing to give the applicants additional time, because we in the rules we provide for a limitation on from the time you take step one and begin the process, how many years you have to complete the entire sequence. And we added time, but we could do that with emergency rules if that were to come up.
As long as we can be nimble if we have to.
Yeah.
Yeah,
And again,
Dr. Ireland, this is also for PAs and AAs, which have a completely different testing process.
RAs and AAs.
Yes. Yeah.
So, yeah, I mean, I think the other thing is, no, I think that's, unless there are other questions about it, I think we propose that would go away. It doesn't really serve it doesn't address a need, I guess, is our view on it. So that takes us to number 19, which I already covered up front, giving you the background on the change in the non-disciplinary financial penalty, which is currently 25, and the board voted to increase for the penalty to be at 100 to 250, depending on the circumstances. So that's you've endured my summary of the changes. I haven't seen anybody fall over asleep or
Their cameras are off.
or
Just as a reminder to folks on the board, a lot of this work came, and David had mentioned this, at the request or the demands of the legislature to look at our process because efficiency was highlighted as a concern, how long it takes to get a license. The sort of main things we did, move to FCVS. That will make the process quite a bit more streamlined. It allows for verification of identification and all the secondary verifications, which are one of the largest delays in getting not only licensed but credentialed. But then the certification of identity was a big holdup for some people, and then the reference pieces. So we tried to address those in these rules, and that's sort of where a lot of this came from, was just to try and make this faster for people to get a license in Vermont. All right, I'm going to stop talking. Pat has her hand raised.
Okay, thank you. I agree with the changes. I think they are good changes, FCVS, as well as the change in well, that's the birth certificate, as well as the other changes. I had a couple of questions. One is on the fifth pathway, which really wasn't. So both of my questions are really not part of exactly what David spoke to, or what the board has discussed in your previous meetings regarding these changes. But I was struck because, one, I've never understood the fifth pathway. And I don't know that we've ever used the fifth pathway, but I'm also aware of the other legislative kind of ask that's coming our way is regarding licensure of international medical grads using the non-traditional kind of pathways, I'll call it that, or the FTP or whatever it's going to be called. So we might probably will have to revisit the fifth pathway, but there are some things in there that are in the criteria that are extremely confusing to me. And so I just wanted to bring that up, not to belabor it, but again, and I don't think we've ever used it, but I think it would be readdressed if we talked about other forms of licensing for international medical grads.
Now, I know it's come up from time to time, Pat, and I'm going to ask Tracy. She's one of the few people. This is like Tracy. I'd compare it to being able to speak a dying language. It's it's one of those things that's going to stay around as long. I don't think the fifth pathway is used anymore, but as long as there are still people who became licensed using the fifth pathway, we need to keep it in our rules. So Tracy, do you want to respond?
Yeah, so yes, the fifth pathway is basically, the easiest way to put it is kind of like an extra year of medical school that goes into a type of postgraduate training. It's kind of a bridge for them to kind of learn US ways, Canadian ways, but we actually just had someone who came in using the fifth pathway for their approval instead of ECFMG. And we don't see it often, but we do still see it, especially on some of the docs who have been practicing a while. So I'm not sure I'm not sure what question you specifically want answered, but
well,
it is confusing, but yes, we do still get them. And it's actually, there's a form and it's sent to the medical school where they did their fifth pathway year. And it's completed and sent back to us. So, and I think I've seen maybe 4 in the entire time I've been with the board.
Right.
So,
right. I didn't recall ever seeing when I was on someone like this, when I was on licensing committee, but I think it has, and it probably will be people who have gone through this or have had their education quite a while ago. But going forward, there are some things in the way it's worded. It talks about medical schools outside the US recognized by the World Health Organization, and that isn't really the way the accreditors are recognizing schools anymore. It's more through WIFME accreditation. And so those things have changed. And it also, go ahead.
Oh, just on that one, Pat, I think it's when the fifth pathway was being used, WHO was they were the ones who were certifying them. So that's the authority that was relevant to the fifth pathway.
Right. WFME came out of the WHO, right? I mean, that was
yes. Yeah. And as of 2026, I believe now, all the medical schools will have to be approved by an authority that is accredited by the ECFMG. So, which also gets a little confusing because right now, people who have taken their ECFMG doesn't necessarily make them having attended a qualified medical school. So they're two very different things. Right. ECFMG will accept any school pretty much. To take that ECFMG, as of 2026, it will be strictly ECFMG. If the ECFMG does not have an accrediting authority that is approved, for that country,
Yeah.
that medical school, the graduate from that medical school will no longer be able to take the ECFMG exam to use it to come into the United States. So all the countries right now are in the process of becoming accredited through the ECFMG organizations. So it's
Right.
huge.
Yeah, and I realize that, but so I would wonder, how can we make this only apply in not a going forward way, but in a more of a retroactive way, similar to what was done in the rules for the MBME exam. So that was people who graduated before 1994. After 94, MBME graduates, the MBME didn't exist actually any longer. So the USMLE started. And so that's written, and we don't have to belabor it actually, because we're not going to make those changes, but I just wanted to bring that up. The other thing along those lines is under the USMLE, so the USMLE only allows, the exam itself allows only 4 attempts on every step exam. And we allow unlimited attempts for step 1 and 2, and only 3 attempts for step 3. And I think I recall this from years ago, but since then, since I recall those being kind of approved by the board, the USMLE did really a lot of evidence-based work on what a good attempt level is, or what a good attempt number is. And the 4 is based on the fact that if you do not pass after 4 attempts, the statistics are that your likelihood of passing is extremely low or none. So that was one piece of it. The other piece is exposure of the questions. So when people were taking it over and over again, they were seeing the questions over and over again, and then able to dump those questions on the market, so to speak. And it would potentially compromise the security of the exam. So I don't think we knew either of those things when we settled on no limit of the attempts. And in some ways, it's a moot point because it's only 4 attempts by USMLE. However, the USMLE also says that if you want an extra attempt, if you can ask a state board to approve your application for an extra attempt. So by having unlimited attempts, that really leaves the Vermont board potentially open to more requests from people who have not passed the exam after 4 attempts. And the reality is that I only remember 1 request in the time I was on licensing many years ago.
Do get more of them, Pat, but we've kind of stated, if they've taken more than 3 attempts or more than 7 years to pass those, we have criteria that they have to meet in order to request a waiver to those attempts. They have to be board certified. They have to have the required amount of postgraduate training, so 3 years of postgraduate training in an ACGME, and they have to hold a non-restricted, full, unencumbered license in another U.S. jurisdiction. So we do give them an option if they have passed more, if it has taken them more than the allotted amounts of what the Vermont board allows, to come in still meeting those other requirements. They can request through the licensing committee to have their attempts reviewed, because we don't, in the past, we have not approved a retake of those steps.
No, I know. And it's kind of, they wouldn't be in an ACGME approved program without passing steps 1 and 2. That's the reality.
Right now, guys, we have a hearing at 1 o'clock.
Yeah.
I do want to continue this conversation for sure.
It's just a detail that I think could be tightened up and maybe made simpler, so you weren't bothered by people asking for extra attempts. That's all.
a very reasonable question, Pat, something that maybe the licensing committee could discuss.
Yeah.
But let's move on to our 1 o'clock hearing. We have, Peter, we'll get back to your question as well afterwards. Evan had also had a question, but we will get back to that after our hearing, okay? Next item of business is our hearing, and I see Mr. Belcher is with us. Good to see you, George.
Hello. Are you ready to go forward with that, Dr. Chair?
I sure am.
All right. I want to call the roll because I wasn't on when the meeting started, and I want to make sure that we've identified who's participating in the meeting. This case is coming for the North Committee. So if I call your name and you're on that committee, just please say that you're abstaining or recusing. And I went on the website for the list of members, and I'm not sure that the website has a current list, but I'm calling the roll.
Would you like me to run through the roll for you? I mean, I've got the current list if you want.
Sure, that would be great, David. Thank you.
Okay, Dr. Rick Hildebrandt.
Here.
Rob Chapanelli.
Here.
Dr. David Coder.
Here.
Okay, and I will skip the North Committee members. Gail Falk.
Here.
Dr. Rachel Gatus.
Gatus.
Here.
Dr. Matthew Greenberg.
Here.
Dr. Peter Ireland.
Here.
Suzanne Jones, PAC. Stephanie Lawrence. Dr. Ian Odeji.
Yeah.
Dr. Robert Tortolani.
Here.
Scott Tucker.
Here.
That's all the members.
So did I understand that Stephanie Lorenz is not participating?
Oh, I'm sorry. Yeah, she is not on. Yes, she's absent.
All right, great. So thank you. And I see that we're on the record. The date is August 7th, 2024, before the Vermont Board of Medical Practice. The board is considering a cessation of practice agreement for Dr. Adrian Kahn, MD. The docket number is MPN 091-0524. And we just took the roll. Representing the state is Mr. Reynolds involved?
Yes, I am.
All right, thank you. And is anyone participating on behalf of Dr. Kahn, or is Dr. Kahn participating?
Dr. Kahn and his counsel were provided notice of today's meeting, and they have both declined to participate in today's meeting.
All
They
right,
will
thank
not be
you.
appearing.
All right, thank you. Go ahead, Mr. Reynolds. You can present the agreement, please.
Yes. Dr. Adnan Khan of New Hampshire holds a medical license that was issued by the Board of Medical Practice on September 3rd, 2014. The respondent was criminally indicted on April 18, 2024 by a federal grand jury in the District of Vermont on charges of conspiracy to distribute narcotics, sale, distribution, or dispense, attempt and conspiracy to commit fraud, and healthcare fraud. The respondent has voluntarily agreed to enter into this cessation of practice agreement with the board and agrees to immediately refrain temporarily from any and all practice of medicine until further order of the board. The respondent and his counsel have signed the agreement, which can be found on page 102 of the board packet. The terms of the agreement are as follows. First, the respondent shall cease and desist immediately and hereafter following his execution of the agreement from all practice of medicine in the state of Vermont. The respondent shall neither prescribe nor dispense any drugs to patients, associates, himself, family members, or others after the execution of this agreement. Respondent shall execute and submit a voluntary surrender of controlled substances privileges document with the U.S. Drug Enforcement Agency. And he acknowledges that by submitting this document, that it will result in his immediate termination of his DEA privileges. And respondent agrees that the board in its sole discretion may consider and approve a petition from the respondent at a later date for modification or relief from the terms and conditions of this agreement when his personal circumstances so warrant. And so those are the main provisions of the agreement, which again is contained in the packet. And we would look for a motion to approve.
Are there any questions by a board member of Mr. Reynolds? Is there a motion by a board member to approve the cessation of practice agreement?
Motion to approve the cessation agreement, Greenberg.
Thank you. Is there a second?
Second, Tucker.
Thank you. Is there any discussion? If there's no discussion, I'll call the roll. When your name is called, please say aye or yes or no or nay. Mr. Ciapelli,
Yes.
Dr. Kader,
Yes.
Ms. Falk,
Yes.
Dr. Gades,
Yes.
Dr. Greenberg,
Yes.
Dr. Hildebrand,
Yes.
Dr. Odeji,
Yes.
Dr. Tortolani,
Yes.
Mr. Tucker,
Yes.
and Dr. Ireland.
Yes.
So that's the roll unless I missed someone. And the vote was unanimous, so the cessation of practice agreement is approved. And there's a signature line on that for the chair to sign. Unless there's something further for me. Thank
don't
you
think
all
we have
very
anything
much.
else.
Have a great day.
Thank you so much, George. Always a pleasure.
Thank you, George.
All right. Shall we get back to our previous discussion? So Pat had brought up a number of good points, discussion around should we be having some kind of statement around the fifth pathway and how it relates to the old versus the current process, and ensuring that the timeframes for using something like the WHO versus WHME is appropriately documented. And the other one was around, I forget, Jesus, I'm blanking already.
It's the attempts on
Oh, attempts on
USMLE.
USMLE. I would propose, if the board is open to this sounds like something the licensing committee could discuss and perhaps, make a recommendation to us on. I don't know that this shouldn't hold up the changes that we have proposed, because these are statutory changes that are going to take some time. But perhaps this is something that could be taken up by the licensing committee. And if there's a recommendation to the full board, we could make those changes at a later date. Unless, David, you think we should do something differently.
No, and I think one thing I wanted to say about that, Pat, was that during the time when you weren't on the board, we've gone over it in detail at least once. And the board made carefully considered the number and looked at what all states are doing, and decided to keep it at the levels where we are. And I've been providing quite a bit of information typically about the USMLE. I'm on the advisory committee for the USMLE, and so I've been passing on the information about the efforts to use evidence-based practices and setting the requirements. And I think that it certainly can wait for the next round of changes. And I think we can anticipate that there will be some with all the discussions about our foreign trained physicians. That it won't be too long before we're looking at more statute and rule changes.
Agreed. Okay. And we had two other folks who had their hand raised, Dr. Eiler and Dr. Ireland. I'm going to start
I'm going to
alphabetically.
table my stuff for now. I think
Okay.
that, there's lots of other things we could discuss, but I want to stick with the substance but also do want to commend all the people who worked on this. This was a huge undertaking, and David, thanks for summarizing. Yikes.
Agreed. And Dr. Ireland.
I think all the proposed changes seem reasonable. I think it addresses the administrative burden that we're hoping to address, Dr. Hildebrand mentioned. I think it's just worth pointing out that it does raise the cost of the application from the $650 now, with the required SCVS packet of $400 fee, from $650 to $1,050 for an initial application. I don't have any solutions to that. I think it's just worth noting.
Yeah. And I'll tell you what feedback we heard. Couple of things. One, we heard timing. And admittedly, this was mostly from UVM, okay, or the larger organizations, but it was more about timeliness. I don't think we get nearly as many complaints about the costs, because I think we're frankly on the lower side in terms of licensure costs around the country. The other piece is the number of people who don't ultimately end up requiring FCVS just for credentialing purposes is pretty darn small. It's not zero, but if you're on the medical staff of any hospital, you're going to get FCVS. If you're on the medical staff of any large FQHC, you're going to end up with FCVS. And it's not to say that there's zero. There certainly is not. There's other practices that don't require it, but most of the medical staffs around the state do require it. So completely, you're right. It raises the cost, but I think it's in totality probably a small number.
The idea that UVMHN is accusing anyone of being slow strikes me as a classic example of projection, but we'll leave that for another day.
No comment.
This might be a good time to remind everybody we're being recorded.
Tracy.
I was just going to point out with the cost, most medical schools and postgraduate programs are now starting to charge to get verifications completed. So it's not really upping the cost once you go through especially for some of the physicians who have gone to several programs and gone to fellowship and then do research. And so it is evening out a little bit with the schools and the programs starting to charge.
As a frugal, lowly primary care provider, I managed to avoid it, and it probably cost about $60. And all of this in context of, these are physicians, small cut of many, but just worth noting.
For sure. Dr. O.
Well, I was going to say, I was very happy they took the birth certificate and naturalization away. That was pretty good.
Yeah, I'll tell you, I have a little PTSD. The Malaysian embassy situation that I had to deal with, where the place burned down or some war. I don't know what it was, but it was a nightmare. And getting a birth certificate is not always as easy as it sounds.
Not easy.
All right. Any other discussion on this item? David, are you looking for a motion here?
Yeah, if people want to, if people are good with doing a motion, that would be good. That makes a very clear statement that I can pass on to the the Department of Health and the stakeholders, and when we get with the legislature, that the board did formally approve these.
Is someone willing to make a motion regarding the proposed changes to our board rules?
Motion to approve, Ireland.
Can I get a second? Great. Any further discussion?
Who seconded?
Ian Otaji. Any further discussion? If you're all ready for it, all those in favor, please say aye. Aye.
Aye.
Any opposed? Abstentions or recusals? And please note that it was unanimous. Great. Sorry, I had to go back to the top of this page because it's really long with the couple of things in there. Anyway, I think next up is for us to go into executive session. Now, typically we would discuss having a break, but it hasn't been that long. Are people okay with going right into executive session and maybe taking a break after we're done? Yeah, I'm seeing head nods. All right. I'll
Rick,
take a
I'm
motion.
sorry. I need
Oh,
to.
sorry.
I'm going to need a minute just to run and get something out of the printer. I need a document for when we go into executive session.
Okay,
So I'll just be a minute getting over there.
that's okay. Can I get a motion to go into executive session though, please? Pat, raise your hand.
So move.
Can I get a second?
Second.
Second from Otaji. Any discussion? All those in favor, please say aye.
Aye.
Aye. Any
Aye.
opposed? No.
And
We'll
can we
see
just
you-
have the clarification is it's to discuss, did we already say this and I missed it, to discuss matters that are confidential by law, which all of our cases are.
Correct. Sorry, I didn't specify that because I was being quick, but yes, that is the purpose of the executive session. All right, we'll see you on the flip side.
Rick, for some reason, my camera isn't working, so
Okay,
sorry.
we can hear you though.
Oh, okay. Sorry about that.
Yep, no worries. I think we've been through it all over the last 5 years of
I know.
streaming errors and lawyers dressed like cats and everything else. So
Rick, I just wanted to say to Peter, our new member, I just wanted to say when we used to meet monthly together as a group, it was a lot easier to meet people and to greet people. And we really want to welcome you. I know it's very difficult when we're meeting this way, but it's so nice to have you. And we all feel that way. I wish we were meeting together.
We do try and get together occasionally, but we don't do it every month any longer, which for many of us the drive was a bit much. But we do have some opportunities to connect, and the committees do connect as well often.
Yeah, Rick, maybe, I know it's been a long meeting, but maybe we should take a minute after we finish up business and everybody, I neglected to invite everybody to introduce themselves to Peter.
Yep.
Nice. Yeah. Thank you.
We can do that.
Yeah.
Well, sounds good, and I'm up for meeting up whenever it makes sense, and I'm selfishly in favor of getting back to meeting at the board's location, which is across the street from me.
Too funny.
We got 22. I don't know if that's our total number or not.
I think we lost Margaret.
Yeah,
so-
she wasn't in executive session though.
Right.
I think that's probably it then, 22. All right. why don't we reconvene our meeting and we'll start by discussing the cases up for closure. I'm going to start. We in South, we have one case for closure. It's MPS 083-0524, and we propose closing that with a letter 1. I'll entertain a motion from someone other than the South Committee if they would like to make a motion for closure.
So moved, Philibert.
Great. Can I get a second?
Second, Greenberg.
Second, Scott.
Okay. Any discussion? All those in favor, please say aye.
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 Any opposed? Abstentions and recusals, please send to David. Next up, we'll go to North.
Okay, we have 3 recommendations for closures. The first one is MPN 1420423. Recommend closing with a special letter 2. The next one is MPN 1410423. Recommend closure with a special letter 2. And the third is MPN 0560324. Recommend closure with a special letter 1.
And
So
I'll
moved.
entertain- Great.
Second.
Great. Any discussion? All those in favor, please say
Who was
aye.
the
It
second?
was, we had Bob and Ian.
Yeah.
Great. All those in favor, please say aye.
Aye.
Aye. Any opposed? And abstentions and recusals, please. Oh, actually, Bob, did you not recuse on one of those cases? You can't motion it. Can we get someone else to make that motion?
Somebody else to second.
Oh, I'm sorry. Okay.
I think Judy seconded it as well, didn't you, Judy?
Yes.
Okay.
All
Thanks for that. Yeah, thank you.
All right, so we had Judy and Dr. O, and we already took a vote. Any opposed? No. And then abstentions and recusals go to David. Thank you.
The recusal
and-
here,
Yes.
Padilla recuses on the first 2
Yes.
cases.
And last up, Gail with Central.
Right. Sorry, my camera is off too. Central has 6 cases to close. MPC 0620324 closed with a special letter 1. MPC 0820524 closed with a regular letter 1. MPC 1931023 closed with a special letter 1. MPC 0870524 closed with a letter 1. MPC 0880524 closed with a letter 1. Finally, MPC 1951023 closed with a special letter 1.
Can I get a motion from someone other than Central?
So moved. Philibert.
Don, can I get a second?
Second, Tucker.
Great. All those in favor, please say aye.
Aye.
Aye. Any opposed? And abstentions and recusals, please send to David. And I believe Dr. Eiler was hoping to make another motion now that we're back in open session.
Yes. I rise to move that this body create a work group charged with reviewing at least a subset of the cases that have come before the board regarding bad outcomes in corrections, with the goal of evaluating and summarizing system problems that may exist in the healthcare system within Vermont Corrections.
Would anybody like to second?
I will second that, Philibert.
What discussion do we have on this motion? Hearing none. All those in favor, please say aye.
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 Any opposed? Any abstentions or recusals? Great. Well, that's essentially the end of our meeting, unless there's any more items to come before open session.
Well,
Any
Rick, I
other-
think we're gonna,
Yep.
I do have one item that I skipped over in my admin update, and that is we had a couple months ago, we had a few of you volunteered to be on an ad hoc committee, and I to work on the update to the opioid policy. And I hadn't gotten back to you all yet on that. I will be sending out a draft soon. And so that will be coming your way, just a heads up on that. And can we run through the role, and you can introduce yourselves to Peter?
Absolutely.
Okay, so Rick, we'll start with you.
Rick Hildebrandt. I'm the chair of the board. I am a hospitalist. I've been practicing in Vermont for 13 years now. I have a number of administrative functions and titles as well down in Rutland, and I don't even know how long I've been on the board.
Five and a half or so.
Yeah, because I started around the same time as Bob, around 5.5
Not
years.
long enough.
But that's me.
And Rob Chapinelli.
Hi, Rob Chapinelli, public member out of Warren, and been on the board just about a year now. It just hit the 1-year anniversary, and come to the board through a connection to David, and having spent about 35 years on the biotech side of the world in healthcare.
And Dr. Coder.
Yeah, welcome, Peter. I'm Dave Coder. I'm up the road in Morrisville. I'm a family doctor, partly retired, and I've been on the board now for about 16 months or so. Still learning. Welcome.
And Dr. Eiler.
Hi, Evan Eiler. I've been on the board for a little under a year. I did family medicine for 16 years and then a second residency in psychiatry, and then both for a while until it became administratively unbearable. At this point, I work at UVM Medical Center and a little bit at CVMC, seeing primarily people with very severe psychiatric illness.
And
Thank you.
let me see. Well, I know you met Gail Falk at the central meeting, I believe, but Gail?
Right, so I've already met you. I'm the chair of the Central Committee, and I live in Plainfield, and I look forward to meeting with you on the Central Committee.
And same with Dr. Gatus, and you know her anyway, and Dr. Greenberg from Central Vermont. So we'll skip right over you guys. I'm sure you're okay with that. And Suzanne Jones is our PA member. She's absent today. Next is Dr. Pat King.
I think she had to step out.
Okay. And Stephanie Lawrence is absent. She's a public member on South. Dr. Odiji.
Ian, you're muted.
I'm Ian Odike. I'm one of the podiatrists. I have a private practice in Rutland. I see patients in Rutland Hospital and at Springfield too. I've been a board member for about maybe 3 months now, and I've been in practice for almost 4 years. Pleased to welcome you, Peter.
Thank you.
And Don Philibert.
Hi, Peter. I have been on the board for about a year. I'm a retired social worker who spent most of her career on health policy issues and public health. I know David through working with him at the health department, and it's good to have you on board.
Thank you.
Dr. Margaret Tando had to leave. She's a trauma surgeon at UVM. Dr. Tortolani.
Yeah, hi again. Well, welcome, Peter. So good to have you. I live in Brattleboro. I was in solo private family practice for 44 years in Brattleboro, and now I'm in post-practice period, which is very active and exciting. I'm chair of the licensing committee, and I'm enjoying my time on board very much. I hope you do too.
Fantastic. Thank you.
And, oh, I skipped over Judy Scott. I'm sorry, Judy.
Not at all. I want to welcome you. I also am a pretty new member. I've just started pretty much at the beginning of the year. So I'm still learning and very much enjoying getting to know all the other members of the board who are very interesting people. My background is in refugee resettlement and interpretation services.
Great.
So welcome.
And
That's fantastic.
Scott Tucker.
Oh, welcome, Dr. Ireland. Sorry about my picture today. I am formerly a law enforcement in the Rutland City area. I retired from the Rutland City Police Department about 7 years ago. I did something there called Project Vision, and really it was a focus on initiatives and solutions focused on neighborhoods in the opiate addiction field in the law enforcement realm. But we brought in all kinds of different partners during the 3.5 years that I was the executive director for that operation, which is probably the highlight of my career. The town of Wilmington, a little bit south of Rutland, took me in as their town manager. I've been here for 7 years.
That's great.
And then just a couple of us, I think you met Megan and Kurt at the central meeting, I believe. Were you at the central meeting, Kurt? Yeah. Bill Reynolds was absent. Bill?
Hi, Peter. I'm also a fellow resident of Waitsfield and former prosecutor with the Bronx DA's office and then in Vermont. And I do part Med Board, but mostly labor and employment law and before the Labor Relations Board and Vermont Human Rights Commission. So good to see you. Maybe we'll see you on the slopes at Mad River or Sugar Bush.
If not there, around Mahurins.
Right, so, and I think the other staff is off who you haven't met, so that's everybody.
Great. Fantastic. Great to meet you
all. Matt had asked a question in chat, and people who are interested in joining the subcommittee on corrections review, please do let David know. You can shoot him an email, and we'll work on spinning that up. For those of you who are interested, it is entirely for entertainment purposes only. It is not investigative journalism, but I linked a John Oliver expose on healthcare in the corrections that is interesting. But it's for entertainment purposes only. We, those of you who have been on long enough know that we got under some heat from John Oliver around Med Board. So he has a tendency to bring heat where it may be needed. So anyway, are there any other items from any board members for open session or open forum? If not, next upcoming meetings are in the packet. And I thank you all very much for your time and attention. Have a good day. Stand adjourned.
Bye.
Bye.
Bye, everybody. Have a nice
Bye now.
rest of the day.